When we examine a patient for lumbar pain, we will first ask the patient how much pain they have, so they will grade their pain level in their lumbar spine or any referred pain they have. Then we'll ask for any movement that we do. We'll ask the patient to tell us if that changed their pain, the pain that they're feeling. So after they've graded their pain and the quality of the pain, we're first going to look at their posture. So we're going to look at the amount of lordosis they have in the lumbar spine, look for any deviation in the frontal plane for any scoliosis, also look for any step deformity in the lumbar area. We'll also look for any type of atrophy in the calves or in the buttocks area. You can also, we suggest you palpate the lumbar spine area, mostly for warmth, and you will do again this palpation at the end of the functional examination to see if there is a difference in temperature. So the first tests that we do are in the standing position. We first ask the patient to put their hand in their lower back, and then we'll ask the patient to bend backwards and come back up. We'll look at the quantity, how much movement, the quality, and the provocation. In this case, you can see about the quality. We're going to look at the curve of the lumbar spine to see if it's uniform or there's one level where the curve is steeper. That might be indicative of an instability or one more part of the puzzle. From there, we're going to ask the patient to put their hand on their side, and the patient will side bend to the left, so going with the left hand on the thigh, on the lateral aspect of the thigh. Again, looking at quality, quantity, and provocation. And then to the right side, again looking at the quality of the curve, and mostly looking at pain provocation. Then we'll ask the patient to bend forward as far as they can, keeping the legs straight with the arms hanging down. Goes as far as she can. Okay, so here in the flex position, we're going to look at the quantity, quality, and provocation of the pain. Again, here, normally a lumbar spine should keep some type of lordosis or go to neutral position but not become kyphotic. If it's kyphotic, it might be also indicative of an instability. In that position, we'll stabilize the trunk and the shoulder girdle, and we'll ask the patient to flex the head forward, so the chin against the sternum, and then bring it back up without movement of the trunk. And we ask if that movement of the head and neck will change their pain. A change in the pain, you can come back up, could be indicative of an affliction involving the neural tissue, dural neural tissue or disc. So then we're going to ask the patient to do a toe raises. So you support the patient just for balance, so you can hold me, and then we ask on the right foot only to go 10 times up, and we ask the patients to go 10 times because often if they have a slight weakness you might not be able to detect it. Then we go with the contralateral side. Again, my hand here on the right side is for balance, but no support on the weight. Okay, and then we ask the patient to do the heel walk. Good, mostly L4 and L5 for a weakness. And then we ask the patient to lie in the supine position. Be careful when your patient lay in the supine position. They might lay from the side-lying position if they have back pain to avoid any trauma to the lumbar spine. The first testing that we will do is the testing of the sacroiliac joint. So here, to position the sacroiliac joint in the maximal loose back position, we'll position a pillow underneath the knee of the patient, so the hips and the knees are about flexed at 15 to 20 degrees. Then you'll position your hands on the ASIS, the anterior superior iliac spine. Cross your arms, and in that position you'll produce a pressure in a posterior, slightly lateral direction to allow for creep deformation of the sacroiliac joint. Will hold this position for up to 3 minutes as necessary, and then we'll do an overpressure. Now, if the patient reports pain, unilateral pain, it might be coming from the sacroiliac joint. It might also be coming from the lumbar spine area. To avoid this, we ask the patient just to put their forearm in the lower part of their back, so all across. If it's not comfortable, they can put both hands or the forearm all the way across the lumbar spine area. If you repeat the test like this, this position is the lordosis of the lumbar spine, close back position of the lumbar spine. It'll be more specific for the sacroiliac joint, avoiding any movement in the lumbar spine area. And then you can do your overpressure. Then we'll do the straight leg raise. For the straight leg raise, we first do a slight flexion of the knee and hip, and we dorsiflex the ankle, extend the knee back. That straight leg raise with distal initiation, starting with a distal pull on your neural tissue. Go until you feel resistance or pain. If that reproduces the pain of the patient, you ask the patient next to raise up the head, to tuck the chin. Hold your head there, and then you release the pressure on the ankle. Then you ask the patient just to lower the head down. This is straight leg raise with distal initiation. If the patient has maximum amount of pain or reproduction of their pain, when you're in the maximum tension, straight leg raise with dorsiflexion and head flexion is that's the most painful test. That means that they have a tension problem. Then you might not be, it might not be necessary for you to do the straight leg raise with proximal initiation. You need, although, to do also the test on the contralateral side. I'll stand on this side so you can see, but the same, bending, dorsiflexion of the ankle, raising up the leg until you feel pain or tension. The patient asks you to stop. And then again, a chin tuck, looking for changes in pain. The patient keep the head there, and then I release the foot, and then she can release the head. So this is the straight leg raise with distal initiation. Straight leg raise with proximal initiation, if the first one is not positive or not clear, you may do the straight leg raise with proximal initiation. In this case, the patient is first going to raise the head, and then in that position, I'll bend the knee, dorsiflex the ankle, here, and then from that position, ask the patient just to lower the head down, see if that changed their pain, and then release the leg. The same would be done with the other lower extremity. Then we'll start our testing to rule out any hip pathology, as the hip is also a joint that can refer pain to the buttock or the lower leg area. So we'll start with hip flexion. For the hip flexion, I position my thumb in the ASIS area. When the ASIS starts moving, I do not have any more pure hip flexion. Then I position my hand underneath the pelvis for stability and go all the way to end range in flexion. If no pain, you can add a little overpressure. Again, I'll stand on this side to show you the contralateral side, looking for movement at the ASIS, and then blocking here the hip to the end range and overpressure. Then we'll look at internal rotation of the hip. Again, we flex the hip to 90 degrees. At 90 degrees, we're going to internally rotate. When I feel the ASIS moving, that's the end of the pure coxofemoral movement. And hold the thigh and go to end range overpressure. Compare to the other side. And then I'll do external rotation, 90 degrees. I'll take the hip into external rotation until the ASIS starts moving, and then go to the end range and overpressure for pain provocation. I would do the test also on the other side. So that's to rule out the hip joint, to help you ruling out the hip joint. Then we'll start our resistive test. The resistive tests are mainly done for weakness for the lumbar spine. So we're not really looking at tendonitis. We're mostly looking at weakness in those resistive tests. First resistive test is hip flexion. So the patient is going to be asked to raise up the foot of the table and pulling toward my hand. Pull as hard as you can, slowly increasing. Pull, 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 and relax. Again here, the direction of my arm, again I would change position, but for the camera I'll stay on this side. You be sure that when you do the resistive test, your arm is perpendicular to the thigh. So here, then you ask your patient just to pull, 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 and relax, mostly looking for weakness. Then we'll test the lower roots. We'll start with the tibialis anterior, mostly the L4 nerve root, and we'll ask the patient to pull the foot toward my elbow, so up and in. So toward my elbow here. So here she's toward my elbow, she hold it there, and then I push down, looking mostly for weakness. In the other direction, pull up and in, pull, 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 and relax. For all these testing that you do in the for the lower extremity, for the feet, we recommend that you repeat these tests 10 times if you believe there might be a weakness or the patient has in the history of weakness. So then you'll test the extensor of the big toe, which is nerve root of L5. So ask the patient to extend the big toe, test 10 times, and look for a weakness. Okay, raising up the toe, hold it there, and then I'll push down 10 times, asking the patient just to hold it 9 and 10 for weakness, the L5 root. And then we'll test the peroneal muscles. So in this case, we're going to ask the patient to push in push toward my elbow, down and out. Push, 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 and relax. And here, push down and out. Push, 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 and relax for your peroneal muscles. So then you'll do your reflex. So reflex, you want to do your patellar reflex. Again, for any anomalies on the patellar tendon, so the leg is resting. You might tap a few times just to rest the quadriceps, and then you just hit the tendon, and you'll compare to the other side. So relaxing the quad, and then hitting the tendon. You just look mostly for asymmetry between the reflexes. And then your foot sole reflex will do, so your Babinski foot sole reflex, so you're going to start on the most posterior aspect of the plantar aspect of the foot, going lateral on the plantar aspect of the foot, and coming back to the big toe. So like this, and what you're going to look for is for an extension of the toe and separation of the toe and extension of the big toe for a positive test for upper motor neuron affliction. So here on the other side, here going lateral and back toward the toe. Normal is for the patient just to retrieve their toe and flex the toe. If it's abnormal, they're going to extend, separate the toes, and extension of the big toe. Then we'll ask the patient to go in the side lying position. So, in that side lying position, we'll perform our next sacroiliac joint testing. The hip and knees flex about 15 degrees. In this position, you'll locate your iliac crest, and with both hands, you'll push in a medial direction. This is one of the least sensitive tests for the sacroiliac joint pathology, but looking also at pain. For creep deformation, you hold this for at least 45 seconds, but you may hold it up to 3 minutes. At the end, you may do an overpressure by movement of the head and trunk and little overpressure. The test should be repeated on the other side. For the sake here of the testing, I'll not repeat it, but you would turn the patient on the other side and do the test. And then we'll do the femoral nerve tension testing. Also done on both sides. I'll just show it on this side. You ask your patient to flex the head forward and hold the knee on the side of the table with both hands. So they flex the hip and hold the knee as far as they can. And then the knee, the leg that you're testing is the leg on the sky side. So what you will do is you'll extend the hip until you feel the pelvis moving. Then you stop. Keep it in the parasagittal plane. Don't let it drop. And then in that position, you'll flex the knee with the hip being somewhat extended. You flex the hip, you flex the knee, and then you ask the patient just to extend the head and see if the extension of the head of the release will change the pain of the patient, their pain. Most people with this test will feel some discomfort on the anterior aspect of the thigh. You just concern, or you want them to report if their pain is changing with the position of the head. So then you would do the test on the other side, and then you do your testing, the final testing in the prone position. So the patient is first laying down prone with the arm at the side. First you're testing for strength. For the gluteal muscles, you'll ask your patient just to squeeze the gluteal muscles, and you'll look to see if there is any asymmetries between the tightness of these gluteal muscles. You may also push and ask them to hold it and see if you can push them, but mostly you look at symmetry in how tight they can squeeze the gluteal muscles. That will be for your sacral roots. And then you'll ask your patient to extend the knee, so arm straight, perpendicular to the tibia, stabilize on the ischial tuberosity and the buttock, and here the distal aspect of the femur, and you ask your patient just to extend the knee, push in the other direction, push down, push, 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 and relax. Most people were looking for weakness. L3, L4, I would go on the other side. For the sake of the camera, I'll stay here. Then you pull down, push, 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 and relax. Mostly for weakness. And then for the hamstrings, you ask your patient just to pull up, pull, 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 and relax. Again, on the other side. About 70 degrees of knee flexion. Don't go too far in flexion, that might create some cramping. It's very uncomfortable. In that position, you ask the patient again to pull the heel toward the buttock. Pull, 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 and relax. So then we'll check the Achilles tendon. Again, relaxing gastrocnemius soleus and tapping on the Achilles tendon a few times and looking for asymmetries. S1, nerve root mostly. For an affliction, if it's hypo, that could be an affliction of the S1 nerve root. Then we have one test left for the basic functional examination, or last test. We ask a patient just to lay prone on the elbows. This is a test that we'll do to give us just a first view about any possibility for instability of the lumbar spine. Again, or repair, PSIS S2, S1, and we first start on L5, spinous process. So we find L5 spinous process. Here, again, you might lower the table. That'll be easier for you. And perpendicular to the curve of the lumbar spine, you take all the slack, so you feel for the quality of the movement, how stiff it is, the quantity, how far it goes, and then feel for provocation of pain. So you'll do mostly this test for provocation of pain. Also to give you a clue if there is any instability, especially a retrolisthesis. If the movement is increased at that level, it might be indicative of a retrolisthesis. So mostly for provocation of pain and also for quantity and quality.